Hello, hello. Happy Thursday, everybody. Well, I'm so excited to see you. Did you miss me? I know it's been, what is it, 10 days since I was last here doing a live. Guys, I had to take a break. I had been just burning the candle on every end, and my body literally said, "Hey, we need a break." So I took a break and I am back. Don't worry, we haven't stopped talking about COVID-19. Indeed, the numbers continue to rise globally here in the United States, while the numbers aren't rising as fast as they did 2 weeks ago. They're still rising. And so we still need to take our precautions. Today, I'm here to talk specifically, though, about COVID-19 and pregnancy. And I'm super excited because I will be joined today by my colleague and friend, Dr. Hariton. And without any further ado, I'm actually going to just bring him on board. Hi, Eduardo.
Hey, how are you, Cindy? Good to
I'm
be here.
good. I'm good. Happy to have you. So, tell us a little bit about what you wanted to cover today. But before we jump into that, actually, tell us a little bit about who you are, because I'm pretty excited so people can know who you are.
Sure. No, thank you for having me. This is very exciting. Like you mentioned, my name is Eduardo Hariton. I'm a reproductive endocrinology and infertility physician. I'm originally from Caracas, Venezuela, by way of Miami, Florida. I completed my training at Harvard Medical School and did my residency also at Brigham and Women's and Mass General, which are two of the Harvard hospitals. And
Yeah,
now I'm at the University of California in San Francisco pursuing my fellowship here. Very excited to be here and excited for our conversation today.
me too. Me too. Now, for those listening, yes, Dr. Harrington and me, we come from the Southern Caribbean. Technically, he's Latin American, but we count Venezuela as
Close enough.
Caribbean. Close enough. Exactly. So, tell us a little bit more about in your day to day as an OBGYN and now a fertility fellow. And as a fertility fellow, really, you guys are in the trenches. You are the ones who are essentially the backbones of a academic fertility practice. I certainly remember my days as a fellow, and it's fun, but it's also a time when you're looking at all the research, all the data, all the studies. What's that like for you in the time of COVID-19 as a fellow, OBGYN, REI fellow, and looking at COVID-19? What stands out to you in that realm?
No, that's a great question. I think you said you're burning the candle at all ends, and that's kind of how it feels like. It
Yeah.
feels like we've been sprinting since March.
Mhm.
And as a fertility fellow, as a OBGYN, as a father, as a friend to a lot of people who are pregnant, thinking about being pregnant, it's a very stressful time. We like to be that person that people come to for advice. We like to be that friend that people can text when they're scared, when they're stressed.
Yeah.
And we like to be that source of information that can make you calm, that can get you through the night. And in the time of COVID, it's been harder. It's been harder to answer questions about what's going on with pregnancy. It's been harder to reassure people that everything's going to be okay. I think at an academic center, thinking about myself and my colleagues, we've been at the forefront. We've been the referral center for Northern California, and we've had some COVID cases, not as many as the East Coast, but we've been dealing with the pandemic head on. And on a personal perspective, I've been trying to consume as much information as I can, stay up to date, and everything changes every day. But really, just try to be that source of information and relay that to my patients, my family, my friends, and try to keep everybody as informed and as calm as we can through this difficult time.
Yeah, and what's that like for you, especially given that you said you're from Venezuela by way of Miami, but now you're all the way across country in San Francisco? How are you, or are you like me, which is I'm here keeping track of what's happening in the United States, but I'm looking at the East Coast where, in my case, there's a huge Southern Caribbean population, but I'm also looking at the Caribbean and looking to see what's happening, how are they managing? Is it the same for you?
Yeah, I mean, I think Venezuela is a little bit difficult because the access to information is not really there. It's hard to figure out what's happening. Reporting isn't great. I'm certainly looking at the East Coast, talking to my friends who are in the front lines of the New York hospitals and getting a sense of what's happening there. We're talking to my family in Florida, making sure that they're okay, getting a sense of what's happening. And I think that there's so much information out there. Some of it is great, some of it is terrible.
Yeah.
And it's hard for a physician with 15 years of training to sift through what is real and what is not. Imagine what it's like for a regular person trying to figure out, what to believe and what not to believe. So I think that in our role as physicians, especially like you and me who are invested in social media, is to try to separate what's real and what's not real and help our patients and our followers make informed decisions that are based on data and not on hearsay.
Yes. And so, how do you do it? Because for me, that's been, I would say, what's kept me up the most at night. It's not just looking at the research papers and the journal articles and trying to find even the obscure preprints before they make it into, major news, and which can be interpreted sometimes not exactly as meant to be in terms of the messaging, but then distilling it for social media. And at the same time, looking at what others are putting out on social media. For pregnant patients, what's been, you find so far, the biggest challenge in terms of things you've had to debunk for your fellow patients, friends, and followers on social media?
I think what I've tried to get across to my pregnant patients is that we just don't know a lot of things. I think that when you look at the timeline of COVID as a virus that started in December of 2019 in Wuhan, China, and has since spread all over the world, someone who was pregnant in Wuhan, China, at the beginning of their pregnancy in December has not delivered yet. So we just don't have a lot of answers.
Yes.
I think one of the things that is most difficult for me is that it's hard to provide true reassurance because we don't know. A lot of what we think about COVID, we're extrapolating from other viruses like MERS and SARS. We're extrapolating for what we think a high fever can do to a pregnancy in early pregnancy, but we just don't know with COVID because the time just isn't there. So I think what I try to do is I try to share, this is what we know, this is what we don't know, this is what we are hoping to learn, and just try to put them at ease in that way. I think that also what I've seen a lot with pregnant women is that you have a spectrum of actions of what you can do. If you're pregnant, you can lock yourself at home, not talk to anybody, not leave your house, not exercise, not walk, not get fresh air, and you're probably not going to get coronavirus if you clean your groceries and do all of that. You could be totally careless, go out without a mask, shake hands, lick the subway. You're probably going to get coronavirus.
Yes.
And there's a lot of things in the middle. And a lot of people who need to live a normal life, a lot of people who are pregnant and need to work to make money to survive are feeling guilt and are feeling like by going about their life, even if they're very careful, they might be putting their fetus at risk. And I think that's a big challenge in an era where we don't have information. So I think explaining what the risks are, explaining how to be cautious, wear a mask, wash your hands, minimize contact, don't shake hands, don't touch buttons, and do certain things that are common sense. And if you're doing everything correctly, but you need to go to work to provide for your family, that's what you need to do. And I think understanding and helping them decide what it is what I try to do. I think from a social media standpoint, I'm not their physician. I'm just trying to help them. I think that's a conversation that needs to happen in the patient room with their own physician and in a case-by-case basis. So that's what I try to do, to educate and empower them to ask the right questions and make the right decisions for themselves.
I agree with you there. And I think, the more we get the messaging out, the more we can actually not just empower patients, but we are also empowering some of our colleagues who may not have the time to do the reading, to look for the obscure pandemic video that runs viral all of a sudden. And so somebody needs to be out there to, clarify things. But I also think it highlights a lot of what we really frustrates us, which is we don't know. And when it comes to obstetrics, when it comes to pregnancy, knowing is a big part of what arms us with information. So I would imagine with you guys being in an academic center, you are also challenged with, well, how do we know? And it sort of brings up the question of research. How do we study this? I've had a lot of patients reach out to me who've said, well, Dr. Duke, do you know of anybody doing research? Is there no one looking to see whether or not this is going to affect pregnant women? And I say, well, some people in China are studying things, but our Chinese patients still may be different from patients in the United States, which is a very diverse country. Or, like we're seeing with COVID right now, we're seeing differences in just how the disease is manifesting in the US compared to the other big places that were hit, which included Wuhan, China, and Italy. So how do you guys address that? What do you do to start to get to that part of we don't know?
Yeah, so we work collaboratively to incorporate all of the research that's coming along. We are lucky in that our infectious disease group is able to pull together a lot of those resources for us. The big UCSF Academic Center has weekly webinars where we go and sift through the data. We try to understand who's at risk, what kind of population is more susceptible, who's more likely to get hospitalized. So, for example, we know that males who are older, obese, and have uncontrolled diabetes are more likely to be affected and harmed by the virus long term. So we are basically trying to understand why, and that's the part that's missing. We're testing therapies at UCSF, so there's different therapies that we're learning have an effect on the virus. A lot of the data that we have is anecdotal, and you have a PhD in this, so you understand this really well. It's really hard to make conclusions based on observational studies because we don't know what would have happened if we wouldn't have given the drug to that person. In order to understand whether a drug works or what happens to a person, we have to test it against the alternative. So we have to give drug A to a person and then give nothing to the other person and get a sense of what happened. And when we do that over and over and over again, we start to see patterns. And even though we have some data that some drugs might help or might not help, we still don't have good data on randomized controlled trials of what's happening there. So I think that's something that's going to start coming over the next couple months, and we'll hopefully get some effective therapies. I know a lot of people across the globe are working on this. I think one of the things is that this pandemic has done is that it's brought the scientific community together. Countries may be drifting apart and politicians may be drifting apart, but scientists and physicians are coming together all over the world to try to solve this problem, because it's not, a Democratic or a Republican or a Black or a white problem. It's a humanitarian crisis, and scientists and physicians are the ones that are at the forefront trying to fix the public health emergency.
And I'm glad you said that, because for me, it's been, I say, one of the biggest heartwarming outcomes that I see coming away from this pandemic is the science world has come so much closer. I've seen people conceive and execute studies in the fastest turnaround I've ever seen. I've seen places now have access to studies. When we think of, for example, the WHO Solidarity Study, which is a randomized study being done around the world with drugs that otherwise would not have been made of, accessible to third world countries, to people of color who typically didn't really have access to certain medications until long after they were already proven beneficial and approved. So that excites me. I agree with you. Now, you mentioned that, some of what you're seeing is that men are more affected, older men, obese men, men with diabetes. What are you seeing in terms of the trends with women and, dare I say, with pregnant women?
That's a tough question, and that's one that we're still trying to solve and understand. I think, when I think of fertility in general, there's the male factor, there's the female factor, and then there's pregnancy. I think what we know about fertility is very limited. There's some small studies that show that you might isolate some COVID RNA in male sperm, but that doesn't mean that this is a sexually transmitted infection. That doesn't mean that it can be transferred. So, like you mentioned, you see the media take on those stories and say, men can transfer COVID to semen, and that's just not true. It has not been proven, and it's something that as physicians who use social media, we need to be very vocal about the fact that that data is just not there. So
and
hopefully,
that study startled me when I saw it in the media, because it was while I was trying to recuperate. And I said, oh, dear God, I can't believe they're out there saying it's sexually transmitted, because patients freaked out.
Absolutely. I mean, and I understand the patients that freak out, but I think we need to be a little bit more rigorous on the media side as to how we interpret data. But that's why we're here, right?
That's why we're here.
I think, the jury's still out, but I think that for all of those that read those headlines out there, we don't know that COVID can be transferred in semen. We know that it is isolated, but also that study, when you actually read the fine print, there is nothing there that said how this, the sperm was handled, how it was collected. So, if you cough in your collection cup, you're gonna get COVID in the collection cup. And there was nothing there about that. So that makes me reassured for now, and I'm looking forward to seeing more data. On the pregnancy side, again, we have limited data. We have some studies from third trimester women who were in Wuhan, China, who delivered, and there seems not to be any strong evidence of vertical transmission. For the people listening, vertical transmission is a transmission of a virus from the mother to the baby in utero. Some infections of some virus are transmitted and can cause significant fetal harm. Zika, for example, varicella, things that we try to vaccinate against. With COVID, we haven't seen that evidence yet. Again, it's been a couple months. It is limited. But for the people who got infections late in pregnancy, we have not seen that detrimental effect. We got to caveat that and say we don't have enough data to say that definitively, but the fact that there's nothing that is coming up showing that it's definitely there is reassuring to me, at least as of now.
And, if we think of the cousins of SARS-CoV-2, MERS and SARS, we also haven't seen evidence of vertical transmission when those were, at their peak. We also haven't seen evidence of birth defects as we see with Zika, because Zika is sort of the most contemporary example that people pull, right? When they're asking, well, how can you be sure that this virus isn't going to harm my baby? With Zika, you guys were telling everybody to avoid pregnancy, avoid fertility treatments. And here you are saying the opposite. And the reason, of course, that we're not saying the opposite, actually, because nobody said anything definitively, but what we're not saying is that it can cause birth defects, is because we've seen from SARS and MERS and other coronaviruses that that's not the same mechanism that they use. But that said, you make a very good point, which is we just don't know enough. So that's actually part of why you're here today, is to tell us how we might go about knowing more. And so what are you guys doing to know more? Because again, that's the benefit of academic institutions, is how you can design things to learn more.
Yeah, I think the other thing before I go into that I think is important to know, and we know this from a study in New York where they tested all incoming women into a labor and delivery unit. They tested some, they had symptoms, those were positive, but then they tested over 200 asymptomatic women. So came in, no idea they had symptoms, no fever, no cough, and over 10% of those women were positive for COVID. The majority of them, some of them got a fever later, but the majority of them were shedding virus, were positive, have absolutely no symptoms, delivered their babies, went home, had absolutely no symptoms after that. What does that tell me as a physician? It tells me that there's a lot of people walking around the community pregnant who do not know they have the virus and are actually actively infected and shedding virus. It's reassuring because they're not getting sick, their babies aren't getting sick, and that's a good thing, but it basically begs the question, what's happening to all those women? Does it matter whether you're symptomatic or not? And that's kind of what we're hoping to study. So to answer your question, I think that one of the things that was most frustrating to me was the lack of data that we had at the beginning of this. no one who was pregnant in their first trimester has ever gotten COVID and delivered, right? Because if you
We
put
have
the timeline, if the first person that was pregnant in Wuhan in December, that was 6 weeks pregnant, then that person is not even in their third trimester yet. So even though it feels like we've been dealing for this for years, it's only been months and we don't have a lot of data. The first trimester is a crucial period in pregnancy.
why
It's
is
a time all the organs form, the placenta develops, the baby's limbs develop, and it's a period that is a complete black box to us as it regards to COVID. So a group of clinicians here at the UCSF Center for Reproductive Health, we have neonatologists, we have microbiologists, we all put our heads together and we said, how can we find out more about the effects of COVID in pregnancy? And the best way that we could think of is we were going to recruit people very early in pregnancy, between 4 and 10 weeks. And that's difficult because no one wants to tell anybody they're pregnant before 10 weeks. But it is the only way we can truly understand, does the timing of infection matter? How does it matter? So we decided to recruit people somewhere between 4 and 10 weeks and study them throughout pregnancy and then continue to study them and their baby until a year and a half of life. And I think as we think of this and as we try to gather more data for our mothers, for our sisters, for our families, for our friends, and for our patients, learning what happens throughout pregnancy and after is what's really going to equip us all, physicians and providers and patients, to get those answers.
Well, it gives us some confidence in our answers, right? You and I both just talked about the fact that we're extrapolating the basis for our answers, but we actually do need a study to actually be able to say confidently, we've looked at coronavirus, meaning SARS-CoV-2, we've looked at COVID-19, and this is what can happen first trimester, second trimester, third trimester, or this is what doesn't happen. Because we need to be able to say that with confidence as opposed to saying based on SARS, based on MERS.
Yeah.
And if we're being honest, based on any one given population. So you use the word recruit. What is recruiting and how are you recruiting?
So this study, we call it the ASPIRE study. And when I say recruit, we want to enroll patients. We want to ask women who feel like they have the same questions or they want answers to the same questions and they want to contribute to the scientific literature. They want to be part of the study. I've spoken to so many women that are frustrated about the fact that we don't have answers. And it's not frustrating in that, like, I'm upset that you don't have them. They're like, she's upset that the world doesn't have these answers. So they want to be part of the solution. They want to contribute. And they say, if I can, put my grain of sand to help get this answer, I want to participate and I want to help. So we're asking women that are between 4 and 10 weeks, adults only, to enroll in this study. They would come to our website, they would fill out a questionnaire, help them figure out if they're eligible, and we figure it out based on how far along they are in pregnancy. And if they're eligible, one of our research coordinators will enroll them in our study. What we're hoping to do is follow them throughout pregnancy. We will check their antibodies. So we don't want them to have to come to the hospital. We don't want them to be exposed. We know this is a big concern for women. So we send them a kit where they can prick their finger and put a little blood in a card. They keep those cards and they can do them every week in the first trimester and then every month later in pregnancy. That's really important because it will give us a sense of when, if they get infected, and we hope that's not the case, but we know realistically at the rate this virus is growing, a lot of our pregnant women will be exposed to the virus. Some of them are already exposed to the virus. They just don't know it yet. So we will ask them to give us this blood sample, send it back to us, and we will analyze it. We're going to ask them to give us their symptoms. So they're going to go through a quick questionnaire daily at the beginning and then a little bit less later on in pregnancy. We really want to focus on that first trimester, but follow them throughout. They'll tell us when they have symptoms, if they have a cough, if they had a fever, so we can really pinpoint the time of infection.
Yeah.
We'll then ask them questionnaires about stress and life, and then follow them. And then we ask them to let us see their medical records. This is, of course, completely confidential, but it will build a really big repository of data that when we have one or two patients, it's hard to tell what would have happened otherwise. But when we start seeing, we're looking to collect 10,000 patients and have them help us get this data. When we analyze data from 10,000 patients, a lot of which are going to get exposed to COVID at different points in pregnancy, we're going to have a much, much better understanding of how this virus impacts pregnant women, how it impacts babies in utero, how it impacts children early in life. And I think it will help us give women answers that we don't have right now.
Now, for a lot of people listening, they're probably thinking 10,000, that's not a big number, but that's actually a massive undertaking.
Yeah.
The truth is, most of the papers that have been published so far, we're looking at numbers like 30, 11, 156 is the biggest I've seen so far in terms of groups of women who've been studied. Well, 200 out of New York, like you mentioned. But really, we're talking at best a couple hundred in terms of pregnant women who've been studied so far. You guys are looking to enroll 10,000. That is a huge undertaking. Now, why 10,000? Just so those who are listening who aren't necessarily familiar with how studies are designed, what is 10,000 here? I mean, in my mind, I'm thinking powered to show a result, but explain to those who are listening why 10,000? Because again, like I said, that's a massive undertaking.
So 10,000 patients is a number that we came in by doing something called a power calculation. So we know that some of our patients, unfortunately, unrelated to COVID, might have miscarriages in pregnancy. We know some of our patients might have things happen and drop out of our study. We hope that doesn't happen, because the more patients we can keep inside, the better the data that we'll have. But we know that if we start with 10,000, we're not going to end with 10,000. Some patients are not going to be exposed to COVID throughout their pregnancy. So they will be helpful because we'll know what happens if you didn't get exposed. Some patients are going to be exposed at different points. And I think that having a large number like 10,000 will help us actually draw realistic conclusions. So we wouldn't be comparing one person to one person. We'll be comparing 600 in this group to 2,000 in the group to 3,000 in the group to however many that didn't get infected. Yeah. And we'll be able to draw realistic conclusions. I think another thing that's really important is that, we want studies to be diverse. We want people to be different. We cannot have, white, hetero, male, female patients that are of a certain socio-demographic class and then say, well, this is what happened to this group of people, so that must be what happened to everybody. We need to make sure that the people that join our study represent the population that we serve. And we know that our population looks very different. Some are Black, some are white, some are Hispanic, some are rich, some are poor, some live in New York City, some live in rural Montana. And we need to make sure that when we do a study, the population that we want to represent is represented in our studies. So we're trying to work really hard to reach people of all facets of life so that we can answer questions for everybody, not just for a few.
Which is good to point out here, because we've already talked about the fact that you are based in San Francisco, but this is not a San Francisco study that we're talking about here. This study is intended for anyone, anywhere in the United States. So you just said that you will send things to a patient. So let's say there's someone listening right now who lives in Central Florida, and you're talking to us from San Francisco. Can someone who's newly pregnant in Central Florida enroll in the study?
Absolutely. And, we started last week. We have people who have signed up in 28 states. We've had 60 fertility clinics who see patients usually earlier in pregnancy. So they're kind of hooked up with these patients. There are partners. They're helping us recruit. They're helping us spread the word. So in a week, we recruited from 28 states. I have a friend who lives in Central Florida who messaged me today after seeing my post on Instagram. She is 4 weeks pregnant. She is incredibly excited. And she said, I had been looking for a way to contribute. This is so important. I need these answers for myself. And even though I might not get them for myself in time, I will get them for my friends. I will get them for my next pregnancy. And she's engaged. So anybody in any of the 50 states is eligible to participate. We will ship our kits anywhere. We want people from all over the place. And if you're not sure, come to our website, fill out our questionnaire. We can let you know if you're eligible or not. And if you're not eligible and you feel like you want to help, share with your friends.
Yes. So you said 50 states, so that means Alaska, Hawaii included. How about the territories? Let's say Puerto Rico. Can they participate, or would they have to be on the mainland?
I actually don't know the answer to that question. We say 50 states and that's what we have, but it is part of the United States. So, if you're from Puerto Rico and you're listening and you want to participate, message me. I'll figure it out for you. And I want you to participate because you're part of our country and we want to have you included as well.
Yes. And why is that so important, Dr. Hariton, in terms of why this diversity and this push for enrolling patients from across the country? Why is that important in this study? And some people would say, well, why is it not just the case for all studies, or hasn't that always been the case?
I think it's been important since the beginning of time, but we've just been terrible at it. I think, we used to enroll white males in studies throughout the beginning of the 20th century. And then we used to say, well, this drug works for white males. It must work for Black females. It must work for Hispanic kids. And that's just not true. Everybody's biology is a little bit different. And not even that, our interventions are not always drug. They're sometimes cultural. They're sometimes educational. There's, the weight loss program that works for me is not the weight loss program that works for you. Right. So we have been used to doing research.
No weight loss program is working for me.
I got that. But yeah, I think doing research in a population that is diverse is extremely, extremely important, especially in something like pregnancy. Yeah. From a geographic standpoint, we're going to see waves that are not correlated throughout this country. We saw a wave in the East Coast. We're seeing waves in some states. The East Coast is getting a little bit better. So we're going to have, not only outside of the pregnancy part, we're going to have a study of asymptomatic infections with COVID that changes throughout the country. So understanding how people in different states are affected is very, very important. I think understanding how people of different socioeconomic groups are affected is extremely important. We're seeing from a study in the UK from the NHS that Asians and African Americans, or not African Americans, but Black people in the UK, they're more affected and worse affected by COVID than white people from the UK. And that's after controlling for obesity, after controlling for gender. And why do we think that? Well, perhaps it's because they're more likely to have essential jobs, so they're more likely to get COVID. But it's something else, and something that we need to look at as well. So we are really, really committed to recruiting a diverse group of people, a diverse group of women who are willing to help us answer this question. And I think that, we would be remiss if we went through the traditional avenues of research, of sending questionnaires, of talking to patients at fertility clinics. Fertility clinics, we know that, and it's one of the shortcomings. It's something that you and me work on every day, trying to increase access to fertility care, trying to find affordable ways for low-income women to get access and be able to build their families. It's tens of thousands of dollars, and it's difficult. So the people that we see in our clinics don't necessarily represent the population in America. I'm hoping that when we're having this chat in 15, 20 years, we will have no COVID and we will have a more diverse population. But for now, yes, we can recruit at fertility clinics. We have outstanding partners all over the country who are excited, who understand the importance of this project, but that's not enough. We need to use platforms like this. We need to use social media. If you're listening to this and you are a woman of color or a Hispanic woman or Native American or low income, and you feel like you've been underrepresented research, and you probably had, please join our study, share with your friends, share with your communities. We want you to be part of this study because we care to understand how COVID affects you, and without your help, we cannot do it.
So let's answer right now the big elephants in the room, especially the big elephants in the room for communities of color, which is the word research, the word study makes a lot of people scared. Um, and you add to that pregnancy, and you can see how some people may initially recoil because they're thinking these people want to do research, they want to test things on me and my baby. And given the historical references to some studies that occurred in the past that did involve people of color, I think we need to address the question, the elephant in the room here. So, first question, is this safe? And why is it safe?
Well, the important thing to note, and I think you bring up a great point, we have done completely unethical, and by meaning we, I mean the medical community, not you and me, but our ancestors in medicine have done studies that have not been ethical and that have put patients at harm. And that's inexcusable.
Inexcusable.
In this situation, whether we like it or not, we are in a natural experiment, right? COVID is going through our communities. It's going to affect pregnant women, whether we want it or not. Whether the Aspire study launches and helps us get some answers, or we shut it down right now, the women are going to be exposed to the same risks. We would never want to expose them to more risks just to do a study. In this case, this is a prospective, which means that we are studying something going forward, observational study. We're trying to understand what happens if people go about their lives in the same way that they would while they're pregnant. So by testing at home, the finger prick might be a little bit uncomfortable, but in the big scheme of things, it's not a big risk. Right. We're asking you to answer questionnaires, and you can do that from the safety of your home on your own time. So we're not really asking people to take drugs or try tests or go to places where they might be worse off. We're allowing people to go about their lives and do what they would have otherwise done, and then just give us the data so that we can find out answers. And I feel like if we were putting people at risk, we wouldn't feel comfortable with it. But I think this is a study that it will benefit women, it will benefit society, it will help providers like you and I go back to the old days where we could provide reassurance and answers and data and really help put women at ease.
And I would tell everyone, full disclosure, I signed my clinic up for this because I read through the study. I
appreciate that so much.
Thank you. And I honestly felt like this study was safe. It was not adding any increased risk to any patient other than just the day-to-day risk that every single one of us is taking right now during a pandemic. Like you said, it's not asking anyone to take any medications. We're not asking you to take not even a vitamin off of this study.
But if you're pregnant, you should take vitamins.
Yes, but you're taking what your doctors recommend, not what this study. We're not studying a drug. For those who are listening, are probably like, yeah, but I bet you some big pharmaceutical company or some vaccine company is behind this. What do you say to that?
There's not. I mean, it's a group of people, a group of clinicians who, we were really helpless. We were seeing this happen around the world. Our patients were knocking on our door and demanding answers. And we said, this is what I know. This is what I can extrapolate from other viruses. And the rest is a black box. And we said, what can we do to make a difference in women's lives? How can we get to the bottom of this? And how can we share that data? Another thing that might be less relevant for our patients, but it was really relevant for our partners, is that this is not something that we're hoping to kind of collect and put on our back pocket. We want this to be an open source database so that our partners can do research. When we finish this study in a couple of years and we have this big trove of data that we've collected so meticulously, and someone from a partner, like if Cindy comes to me and she says, I have a question, you guys said this and this, and that's very helpful, but I don't think anybody looked at the mental health burden. I know you guys have some questions. I want to look into that. And we'll say, come right along, let's answer it. This is a database that we're hoping will serve the world, not just UCSF, not just our patients, but everybody. So we are hoping to make that open source so that people with good research ideas can come in and answer them and then publish them to give back to the community and to give back to the patients who are helping us collect this data.
So really what you're saying here, if any given patient of any community is sitting here and saying, I really wish I could find information that informs my community, this is one way you can participate in this study so that you can finally have representation in the data set.
Absolutely. I think that I would encourage anybody from any community to go to the website, read a little more about our study. We have videos that explain what we're asking you to do. We have FAQs that go through every step of the process. They explain to you what we're asking you to do. If you fill out our questionnaire, that doesn't mean that you're automatically enrolled. We have our research coordinators talk to you. We want to make sure that if you enroll in this, you are fully aware. It's what we call informed consent. It's really important that when you join our study, you know what we would like you to do and you're committed to participating. This is not a 1 month commitment. We're hoping a commitment through your pregnancy and through the beginning of your child's life. It's something that you can be proud of. It's something that you can, say, I made a difference. So when we get these answers, you can say, you know what, I was someone who contributed to this study. And yeah, I did not like pricking my finger, but it was worth it because now we know. And, Cindy, I think one of the things that we don't talk about is that we're all hoping that pregnancy is good, even protective. Maybe we'll find out that people who are pregnant are less likely to get sick than people who are not pregnant. We don't know. But the uncertainty and the stress that causes on our communities, that is very real. Women who are pregnant in America and around the world today are living at a heightened level of anxiety, at a heightened level of stress, and we don't have the answers to bring them back to baseline. So even if we find nothing, which is what I truly hope we do, that coronavirus does not affect women, that would be amazing. But the ability to tell women that for a fact with real data is huge.
Yes, very, very true. And for those who are listening, because we've mentioned over 60 fertility clinics, etc. But let's say there's a patient listening, she did not get pregnant via fertility clinic, or she lives in a state or a city that doesn't have a fertility clinic. Does that mean she couldn't participate?
No, she could still participate. So we have a group of partners that are fertility clinics that are helping us recruit and are engaged in our efforts. But like I said, we are committed to make this open to all women nationwide. So if you are pregnant, you don't have to be a fertility patient. You don't have to have had coronavirus. You don't have to live in a certain place other than the United States. You can just go to our website, aspire.ucsf.edu, and you can just enroll. We will send you everything you need. We'll explain everything to you. And we want to make sure that even people who are not fertility patients or have access to physicians or have seen their doctors can enroll. A lot of patients don't see their obstetricians when they get pregnant spontaneously until 10 weeks or 12 weeks, and it's getting even harder with COVID. So we want to make sure that those women who are in that early phase do get access to this study. And that's why we want people from all communities all over the country to enroll.
So if you're listening, if you're part of a community organization, if you're a nurse, if you're a physician, you don't have to be an OBGYN. If you know someone who's pregnant or could be pregnant and they've expressed interest in finding out more about COVID and pregnancy, this is one way they can actively participate in finding out about COVID and pregnancy, meaning they do nothing differently during their pregnancy except a pinprick at home, a finger prick like you would for, say, a blood sugar, right? Like you would for someone who's diabetic. It's the same kind of finger prick. And then you collect it in a special card type container and eventually you'll ship it back. Everything is paid for by the research group. So you're not paying to ship it. You're not having to do any special storage. So even if your living conditions aren't the greatest at the moment, you can still participate. You don't need a fancy fridge, freezers. You don't need all that stuff. You just need to want to find out more, and you have the assurance this is safe. Now, how is safety in a study determined? And what I'm getting at is IRB. So, how was the safety of this study assessed outside of you guys saying it's safe?
So it's interesting because this is what we mean by burning the candle on all ends. You
Right.
can imagine that going from COVID being a virus in a different country 3 months ago to launching a study for 10,000 people takes a long time. An IRB on average takes months to go through. And this is something that we stood from the ground up pretty quickly. The IRB is the Institutional Review Board. Because of all of the things that happened in the past where studies were unethical, every institution and every time we do research of any kind, there's an institutional review board who is separate from the investigators. So people like myself or my collaborators who looks at our study and says, are they really telling people what they're doing? Are they doing things that make sense? Are they exposing people to risks that are unethical? So that group reviews our study and then says, I think you have to explain this better, or your consent needs to say this, or you have to let people know how they're going to ship their samples or what the pinprick might feel like. But they basically look through everything and they've deemed that our study meets ethical standards, that it's safe for patients, and that people who participate, once they go through our process, which involves submitting that questionnaire and talking to our research coordinators and signing that consent, once you go through that process, then we know that you are truly understanding of what our study entails. And if you do choose to participate, and again, this is voluntary, we appreciate your efforts, but this is not for everybody. For some people, they might read this and say, gosh, I really want to help, but
Yes.
this is not for me. I just can't stick with it for, 18 months or 2 years. We understand that and we appreciate you considering. But for those who do want to help and can help, once you sign those consents, we know, and an institutional review board has agreed that this is a safe study for you and that it's okay to continue.
Good. And I think it's important to emphasize that because, for many people, I think they're not sure how studies are done when it comes to medicine, science, research, and the oversight that's involved. And, I like to point that out because, like we just talked about, historically, there have been events with research that led people to have distrust in medicine. And so it's important that we always point out that the distrust, while based on historical fact, we have lots of things in place to make sure that doesn't happen anymore. And I say that as a woman of color who's a scientist, a researcher who believes strongly that the only way we can make a true change in communities is to have information that mirrors the community. And so that's part of why I'm happy we're here to talk about this because it's so important. Well, Dr. Hariton, we've been talking now for over 45 minutes. I think it's worth checking out to see who's out there in the audience. So we have people saying, hey, Dr. Amy, our mutual friend and colleague, she says, great advice. Lisa, who I'm pretty sure is in the healthcare industry, is also saying so informative. Dr. Amy enjoyed the lick the subway comments. Laura says hi and good evening. Pearl is saying hi. I think everybody was just really interested in saying hi. Gail says hi. Gilda Schlesinger says very proud.
It's my aunt.
That's your aunt. I figured she was family. Irma says good evening. Gilda says Dr. Hariton, impeccable. I agree, Gilda. I agree.
And it's the end of the day.
It's the end of the day. I can see that you're tired. We're going to get you rested soon. Cora says, good evening, doctors. Did I miss much? Cora, you missed quite a bit. You should go back and see the start of this thing. That's my mom.
Or go to aspire.ucsf.edu and you'll see part of what we missed.
Marcos Azulay Bentolila is saying bravo. Very good. Roslyn, good night from Florida. Roslyn is also in the healthcare industry and she's in Florida. Um, and so Lorraine says, mi doctor favorito. You got a fan club here, Eduardo. Cora says, welcome. It's very informative. Uh, Janet says, claro y diafano. Very proud.
Yeah. See, you're getting the bilingual crowd.
I know. We got the.
That's what, that's another thing. That's why I like posting in Spanish in Instagram. I think that when you approach patients in the language that they speak best, I think a lot of what we do in America is in English, and we don't make it accessible to communities where that's not their native language. One of the things that we're doing right now is we're translating our questionnaires to Spanish so that we can reach that community and make sure that that patient feels comfortable in the language that they're used to. So that's what I try to do in social media. A lot of people post in one languages and you tailor it to your culture, which I think is something that you particularly do quite well. But I try to tailor it to the different language so that my Latinos and Latinas in Florida, in Texas, in Arizona, in Latin America can actually get quality medical data from a reputable source.
Yes. And I think it's important that we all keep that in mind because that cultural sensitivity, while language is part of it, it could be more also, things about religion, things about sensitivity as it relates to an examination, sensitivity about how you bring up the conversation about pregnancy and fertility, infertility, and likewise a study related to pregnancy. And so that's part of why I was eager to have you on to talk about it. And of course, if you'd like to talk to anyone in Espanol, feel free. Lorraine says super claro. Again, more, super is Spanish, do a super. And Cora is saying, share the live. Annie says, amazing presentation. Claudia, Salo y Mau, very proud. And the family they're in.
Family strong.
They're very proud.
We're close knit.
Yes, I love it. I love it. And Gilda says, I love that you're doing this study to learn more about the implications and to be able to help more women. I agree, Gilda. And this study is really well designed. Having looked at it myself, I have to agree.
She has a PhD.
Yes, I have a PhD. I have a PhD in microbiology and immunology with a focus on virology. So I really read it through and I was like,
this is the perfect person.
I was like, this is impressive. I like it. And like I said, part of what impressed me was the scope of 10,000, right? The goal of 10,000. For the layperson looking, that may sound like not a big number. But in the world of research where you have to recruit, you have to rule people in and out, 10,000 is a massive undertaking, but a necessary undertaking. And so I applaud it. I applaud it tremendously. And I encourage everyone listening. And so to summarize, we today, Dr. Hariton, talked about COVID and pregnancy, and the fact that we don't know a lot. And then we talked about Aspire and encourage people to get involved in Aspire. And so sort of a parting yet summative speak. Do you want to tell everyone what is Aspire without me interrupting you, and what your goal is from this whole conversation when it comes to Aspire?
Absolutely. So Aspire is a study that a group of researchers, fertility doctors, OBGYNs, virologists, microbiologists, pediatricians out of the University of California, San Francisco launched. We're hoping to recruit 10,000 women nationwide in their first trimester, specifically between 4 and 10 weeks of pregnancy. And we're hoping to follow them throughout their pregnancy and assess if they are exposed to coronavirus, when they are exposed to coronavirus, and understand how that affects moms and babies. We're hoping to do so in a way that is ethical, in a way that makes sure that all women are included, no matter their color, their race, their socioeconomic status, their access to healthcare. It is of no cost to you. It is of no risk to you. And we're not asking you to do anything else than prick your finger and help us with questionnaires. I think that I've gotten an incredible response over the past 24 hours since we went live with our study on social media, of people that say, wow, this is an incredible avenue through which I can share, I can help, I can participate, and I can feel empowered. I have the same questions. My doctor doesn't have the answers, not because they're a bad doctor, because there are no answers. So they want to be part of the solution. And a lot of people have messaged me. They're like, I'm 12 weeks, I'm 15 weeks, I'm 20 weeks, or I'm not pregnant, but my sister is. I told her about it. So what can you do to help? If you qualify, consider joining. If it's for you, we'd love to have you. If it's not for you, we'd still appreciate your time. If you don't qualify for this study, share it with your friends. Share this video, share the link, share the website. People don't tell others that they're 6 weeks pregnant. They wait until they're further along. So you're not going to know a lot of people that are 6 weeks pregnant. But if you post this on your Facebook and your Instagram, and you share with your groups on WhatsApp, people are going to find out. So they don't need to tell you they're pregnant. They'll just come to our website and consider if this is for them. And then the last thing is, if you find that you want to contribute in another way, donate to our study, because doing research is very expensive. I don't get a salary for this. I'm doing this because I think it's the right thing for my patients. We are trying to raise money. We're trying to ask people that have a lot of money to give us big grants, but we're also accepting donations from smaller people. And a lot of people said, I'm not pregnant, but I think this is a great effort. I really want to contribute. And they've donated $10, $25, $100. We're like Bernie Sanders. We'll take any check. We are hoping to get this study to the finish line, and it is expensive, but it is important. And we don't want to wait until we have all the pieces together. We want to get started. We want to take care of you, and we want to get you the answers that you need. So if you're listening today, I just want to say thank you for taking the time to learn more about COVID in pregnancy, to empower yourself, to empower your community, and to move science forward so we can get through this pandemic together.
And if someone wanted to donate, do they go to the same website that's scrolling across the bottom here?
Yeah, if you go to aspire.ucsf.edu, you will find a link there. If you have any questions at all, you can find me on Instagram, hariton.md. You can find me on Facebook. You can email aspire.ucsf.edu, and we will answer all of your questions, and we're here to help.
Oh, I have a couple more questions that have come up that I think are good questions for you.
Of course.
And so let's go ahead and put those. Hold on, I'm just putting your social media here.
Yes, Cindy and I are very close social media friends, always learning from each other, which is something that's important in science. You never stop learning when you're a physician. And it's always nice to have colleagues around the US with whom you learn.
Indeed. So here are a couple questions that we have. So Annie Herman says, how long can antibodies be detected for after the finger prick? And I suspect she's asking because you mentioned that they hold on to the stuff, the supplies, after they've done their finger prick. Or is it they do it, they ship it every time?
So we're having people ship their kits every trimester. So we'll send you a pre-mailed envelope, and once you finish a trimester, you'll put it in, drop it in the mail. We'll get it. We don't know how long antibodies last. For some viruses, the immunity is quite short-lived, in the order of months to years. For some viruses, you get one vaccine and you have immunity for your whole lifetime. So that is one of the things that we are hoping to understand. We also want to understand from symptom onset, that's why we're asking you about your symptoms, until you get antibodies that show up in your blood. How long is that period? We don't know. So we're hoping that this study helps answer some of those questions.
And in terms of just shipping, as someone who shipped antibodies and viruses around the world, what I can tell you is shipping, they can be stable as long as you package it correctly in the right stuff. They can usually be shipped and, temperature controlled. They'll get to where they need to go, no problem, and be assessed. So if you're someone who's worried that you'll have your finger prick done and then you'll ship it and they'll say, oh, sorry, the sample isn't good. It's already been validated and proven that it can be shipped and it can survive travel.
Correct.
For Linda, she says, "Good night, Dr. Duke and Dr. Hariton. Be safe." Well,
Thank you.
Dr. Hariton, thank you so much for joining us here tonight. As we get ready to part, do you want to share any general parting words to our audience outside of having talked about Aspire study?
I just want to say that this is a difficult time. And I think that if you're feeling anxious, if you're feeling stressed, if you're feeling worried about the uncertainty, you are not alone. It feels like you're alone because you've been in your house for months, but you are not alone. Reach out to your support network. We are lucky that we're in the 21st century. We can do FaceTime, we can do Zoom, we can do Facebook. Call your family, call your friends. This is the time to stay connected. This is not the time to go apart. So even if you can't hug someone, and I hope that we can hug people very soon, stay connected to your family. The value of relationships, of belonging is important. And that's something that's not going to change with a pandemic. And I think that the other message I want to share is sometimes you got to shut off the TV station and read a book and shut it off. Coronavirus is all over the news, on every newspaper, on literally everywhere you look, and it's overwhelming and it's a little bit too much at times. Follow people who you trust. Get your information from good sources, but also sometimes it's okay to shut off your phone and do something else because your brain needs a break. And I think that's going to help us all with mental health and with getting through this pandemic in one piece.
Yes. And I suspect this is another family member. Vivi says, "Thank you for the great information. We appreciate you working on the study to help us get informed." I echo Vivi's statement here.
Yeah, my sister's pregnant, so this story is very close to my heart, not only for all the patients that I take care of, but for my sister. So it's something that I'm excited about, and I hope we will learn a lot from people like her.
Por la familia. Is there, and then Jeanette says, "Great message. Stay in touch with your loved ones." I agree, Jeanette. It really is the hallmark of all the messaging is, and if anything, this pandemic's reminded us is to be in touch with our family. And Gilda says, "Venezuela is proud porque de aquí vienes tú y tu abuelo que estará orgulloso en el cielo." Did I
My
say that?
grandfather was a physician who I'm sure is watching from up top.
Yeah, very nice. Well, Gilda, I appreciated the support. We are all equally proud of Eduardo, and we're rooting for him in fellowship in this amazing study. Thank you so much, Dr. Hariton. And everybody, stay tuned. We'll see you next week. Until then, good night.
Thank you.